directive or any will the patient has, and encourage mutual respect. Both perspectives aim for the patient's best interest. So it should be the final, the conclusion should be, it should be for the patient's best interest. It's not for the doctor's ego or the nurse's like no own perceptions. Now the next scenario, two patients require the last ICU bed. Clear. This is again a very interesting conflict. A 45-year-old post cardiac arrest with good neurologic prognosis and a 78-year-old with severe sepsis and vasopressor. The emergency team pressures for the latter's admission that yes, this 78-year-old guy is known to the emergency team uh, chief. So what will you do? You want the 45-year-old post cardiac arrest patient because the patient had ROSC within 2 minutes and is having a good neurologic prognosis. How do you handle this bed allocation conflict? Anyone? Or you will be taking the patient that you actually like to? Okay. So follow ICU triage protocol, prioritize based on the survivability and prognosis, communicate transparently with the ER team, explain the triage criteria that yes, as per the triage criteria, the 45-year-old post cardiac arrest patient should be given the chance, engage senior ICU leadership, multidisciplinary decision making, offer step down care options if your ICU is full and there is a stable patient in your ICU who can be shifted to SDU, then you can be taking both the two patients and your emergency team will be also happy and you will be also happy. And document reasoning for accountability, like ethical justification why you are taking the patient, the first patient, not the second patient. Now, a 60-year-old post-operative patient developed sepsis in the ICU. Despite appropriate antibiotics, he deteriorated. The family accuses the team of delayed intervention. They are saying that because this patient was not given proper physiotherapy or position changing, that patient developed bed sore, pressure sore, and for that this patient has actually deteriorated and antibiotics also were started late, and that has actually resulted in more and more deterioration leading to patient's death. How would you respond to such an allegation? I have already explained in our breaking bad news, may be similar to that. Remain calm and professional. Explain the clinical course with transparency. Don't try to hide the thing. Offer a mortality review meeting, involve in senior, and then address their emotional distress. Escalate to hospital grievance team if needed. But yes, maintain non-defensive stance. Don't try to defend your team or your role, like no whatever you have done. A 55-year-old patient with metastatic lung cancer has a documented DNR order. The on-call resident, unaware of this, starts CPR after a cardiac arrest. Though it was written do not resuscitate, but the on-call resident, he didn't know it and he started CPR. The ICU nurse protests initially, but finally the resident's lead was followed. How you do handle this breach in protocol? Next day morning when you came to the hospital to take the round, you got to know about all these things that has happened in the night time. So you have to reassess immediately that yes, there is the DNR status is properly documented in records or not. You have to educate the resident post event and discuss the ethical and legal implications if that has been already mentioned, documented DNR. How come he has started CPR? Strengthen the documentation process. Maybe all these things have to be prominently noted. Conduct a debrief with ICU staff, review the lessons learned. Maybe the other staff members should be knowing about that. Yes, there may be the lapse from their side also sometimes, and implement DNR awareness training. Maybe they don't know that there is a concept called as DNR. Clear? Now, there are certain general questions that you need to remember when it comes to the conflict management. What are the common types of conflicts in the ICU that can happen? Conflicts in the ICU typically occur due to high stress situation, ethical dilemmas, and multidisciplinary interactions. The common types include interpersonal conflicts among the doctors, maybe in the same team, maybe in the interdepartmental, nurses and doctors, staff and doctors over the management decisions, ethical conflicts on the basis of end of life care, withdrawal of life support, or DNR order, communication breakdowns between the ICU and the family due to unclear prognosis explanation. There may be conflicts happen due to the resource based conflicts like ICU bed shortage, and there are like a lot of patients in the emergency department, in the ward, in the SDU. Ventilator allocation, maybe the patients are not getting ventilator timely, the BiPAP machine allocation, or prioritizing the patient care, or the nurse patient ratio. All these conflicts may be there. Then decision making conflicts, when the family members have differing views on continuing aggressive treatment. So these are the types of conflicts that can happen in the ICU. Now, what are the principles of conflict resolution in the ICU? Active listening. You have to first understand the concerns without interruption. As the critical care, like senior most person or senior person or responsible person, you should not be having biased answers. Rather, it should be having active listening first, clear, transparent communication, avoid medical jargons, explain all the situations, maybe to the junior doctors, to the nurses in the simple terms, acknowledge the emotions and distress of the patient's family and staff, try to have a middle ground rather than imposing a one-sided decision. You have to take the consideration of all the sides that you are actually having, and escalation to the ethics committee or mediation. If still the conflict persists, never try to solve everything on your own. Try to have a neutral third party for the conflict resolution. How do we handle disagreement among ICU staff? One of your member is saying something and the other member is saying something, or like not having the ideas like there was an taking some other. So to address the conflict, listen and allow both sides to share concerns, mediate difference with a senior intensivist or team leader, prioritize the patient centered whatever will be happening in the ICU. It should be manage the
Progress.
disagreements constructively. You have to describe the problem, express the like argument, like their and counterpoints, specify the solution, the middle path, and again after that you have to check the consequences that can have in the patient management. Now, the legal and ethical aspects, I think would be knowing this, and I think Darshan would be discussing tomorrow the ethics in the ICU procedures. Now, the to prevent in the ICU, the examiner may be keen to know how you are actually handling the communication part in the ICU. Structured family, involvement of multidisciplinary teams, then use of interpreters, language barriers should not be leading to miscommunication, shared decision making, and whatever you do in your ICU in terms of the discussion, transparency in the prognosis should be there. Now, this is the summary of conflict resolution approach. Step one, identify the conflict, acknowledge the concerns and emotion, gather the facts from the medical records, triage criteria, ethical guidelines, engage the stakeholders, whether it is ICU team or the family or the ethics committee or legal advisors, offer a collaborative solution like seek a middle ground, and finally document and follow. So with this, we come to end of I know it's a hectic evening, Saturday evening, maybe holy evening. You should remember forever if this would be coming to the holy when you are getting success this time in your exam. So confidence is preparation, everything else is beyond your control. So with this, I come to end of this, I would say, hurricane mammoth evening where we discussed in detail about two short cases, some of the suggested short cases, and five table vivas, which are very important. And if you answer well, it gives you the confidence, and also the examiner would not be hesitating to give you full marks. Any questions, any feedback, anything you want to share at this point of time? Or you all are so much having conflict in your mind that you don't want to share anything? Okay, perfect. So any questions, anything? Has it been beneficial to you all today's evening? We want that feedback. I will be posting in that group because we will be trying to also be adjusting ourselves. I know it would be hectic, but there is no other way. There is no middle ground. As we have discussed about conflict management, this 5 hours of your time is going to give you minimum 15 days of study. So the resources, the discussion questions, the scenarios that we are sharing is nothing less than, I would say, mammoth task. So I hope you all will be benefited and try to have the confidence within you. So the final bottom line I have actually kept in my last slide, that it is the confidence. And if you know so many things, you listen to such, like, no, very much descriptive and, like, no, trying to summarize everything for you, you will definitely get the confidence. Okay. Take care. Enjoy.